Hi everybody, this is Dr. Donish. I'm a little late today and a little bit sunburned doing the 50 Shades of Pain show, but we were doing a charity event. I'm at the University Club doing the KSR Ronald McDonald Golf Scramble, and so hence the casualness to my appearance, but still wanted to get this done. Still wanted to get out here and talk to everybody about what we're doing, and namely the thing that I wanted to talk about was a condition we call spinal stenosis. That's the thing that a lot of people talk about as they age. It's the issue is that the space in your spinal canal starts to tighten down. The reason that happens is that as you're aging, the ligaments in your spine start to loosen up, and what that does. Hi Amanda, thanks for watching. So as we, sorry, I'm just responding to people that are coming online. As we age, the ligaments in our body, all the soft tissue in our body, starts to loosen, and as a result of that, you get these small movements, that cause the ligaments and the structures in your spine to start to tighten down. The body's responding to that looseness by creating a thickening of the ligaments and other structures in that area, so that you have a little bit more stability as you age. Now, in general, that's not a big deal. It's a good thing, because when you have some instability in a joint, you want that stabilization. But when you're talking about the spine, the problem is that you start to encroach on the space within the spinal canal, and as that happens, as we age, you have less and less circulation to that area of the spine. So you'll see older people, they'll walk around and they'll be all hunched over, or they'll be leaning on the cart. And the reason they do that is because when you arch over like that, it opens up the space a little bit in your spine. And so some of that circulation that's getting congested is able to move out of your back and give you room to have new circulation and increased blood flow. So what spinal stenosis is essentially your body reacting to some instability, and as a result, creating a second problem that you're then using your body movements to try to compensate for. So a lot of times the symptoms they'll get with spinal stenosis is like dull achiness. A lot of times, kind of, let's see if I can do this in this part, the back of the legs. And the more they walk, the longer they walk, the worse it gets, the tighter it gets, the achier it feels in your back. So that people will term as sciatica, but it's one of those terms that sciatica is not one of those terms I like, because it doesn't really tell us anything. There's a lot of other conditions that can also cause those symptoms. Like, for instance, if you have arthritis in the joints of your low back, if you have the arthritis or soft tissue dysfunction in the joint that connects your spine to your pelvis, you can get very similar feelings of pain down the back of your leg. But and the other part to that is that those conditions will also contribute to or cause spinal stenosis, because it's, again, a reflection of that instability at that spinal level, that as you move and walk around, your body tries to compensate for. So the joint thickens, the disc starts to erode a little bit, and it can start bulging backwards, and both of those issues together will cause things to tighten down. So like, let's pretend that this is the spinal canal, the front side being the disc, the back side being where the joints are. Your spine is kind of like a tripod. So with that instability, you start to get bones shifting on top of bones, which causes the disc to bulge backwards and the joints to thicken to try to stabilize that joint. and so things just start to squish in together. Now, traditionally what's done for that is that they'll come in with a surgeon will come in, they have to cut away all the muscles in that area so that they can expose the bone, and then once they expose the bone, then they'll shave some of that bone out, and then they're able to get under that ligament and shave that ligament. But the downside is that when you're cutting away, you're cutting down to the bone, what you're doing is you're destabilizing all of the structures that help to keep that spine stable. Because if you think about it, your spine is composed of bones, joints, discs, but also ligaments and muscles. The ligaments are like the glue that connects the bone together. The muscles are what help change the loading, change the dynamic load on your spine. That's important because if I'm standing here, the load is going straight down, but if I lean forward or if I lean to the side, something has to redistribute that load so you don't fall over. Your center of gravity doesn't just make you collapse. So when you cut away those muscles, you're creating scarring that's going to make increased instability and increase the likelihood of you developing that mobility that I was talking about, that causes that evolution into spinal stenosis, that evolution into arthritic joint pains in the back. So that's one of the downsides to surgery, is that you lose that dynamic stability in your spine. The second downside is that they actually have to carve away some of that bone to expose that ligament. Well, ideally you'd be able to get to the ligament without even cutting out the bone. But when you're going from a surgical perspective, you really can't get the view of the ligament that you need without cutting away some of that bone. So even in they call it microsurgery, even in microsurgery, they're not able to do that very well. Now what we can do, one of the newer treatments is a treatment called mild, and I'll have to redo this show sometime when I have my visual effects. But again, we were out doing this charity event today, so it kind of conflicted with our schedule. So I'll come back and revisit this at some point. But to give you just a brief understanding, what we do with the mild procedure is we come in with a straw, and rather than cut away the muscle, we kind of sneak in underneath the muscle, and we sneak in underneath the bone, so you don't even have to shave the bone either. And then we're able to put in some tools that help us take out some of that excessive tissue growth, excessive ligament growth that's causing the stenosis, and provide a little bit more breathing room to the circulation in that area. As a result, that there's just an immediate effect where people are able to stand longer, walk farther. They don't have to hunch forward as much when they're walking around because they're able to get the circulation they need to the spine, since we've been able to open that up, with the added advantage that we haven't cut away any muscle, we haven't cut away any bone. So the recovery time on these procedures is incredible. I've had patients where they come in and they're really barely able to walk. And after the procedure, they are able to walk home on their own. There's no incision that we have to suture up, so there's really very little recovery time, and people do really well with this. Now, the one thing I'll tell patients is that even though this procedure will open up the stenosis, there were other things that contributed to the that contributed to the whole equation that caused the stenosis. And with this procedure, we're not going to be treating that. We're just primarily aiming at getting people more functional, getting them more mobile, and then we can start working on the things that will be able to help improve their pain on top of their mobility. So we would need to fix some of that instability, some of that looseness that's taking place. Stabilize the joints, stabilize the ligaments or the glue between the joints, strengthen the disc, and we can do all of that with some of the newer treatments in the category of regenerative medicine, where we're actually stimulating the body to layer down new cells, or cells that will grow into stronger ligament structures, stronger tendons, and help to stabilize the spine. We can also teach the patient or the person what exercises they need to do in order to get even stronger than that. So a lot of the things that we once thought of as being end-stage conditions where surgery is really your only other option, we're able to treat with regenerative therapies. So I like to open the floor for any questions if there's anybody in the audience that wants to ask any questions. And if not, I can walk you around and show you kind of what we've been doing today at University Club. So if you haven't been out here, it's a beautiful golf course. And KSR, or Kentucky Sports Radio, is here today. They've got some events going on. They're doing Ryan is going to be doing a putting contest where for every putt that he makes, he gets $1,000 for charity, and for every one that he misses, they've built a jail that he has to essentially sleep in for 2 nights every time he misses a putt. But that's been kind of our day. So I'm sorry I conflicted with doing the show tonight. But I'm glad I got to at least talk a little bit about spinal stenosis and the mild procedure. Again, if anybody, I see some friends joining on. JR, it's good to see you. If anybody has any questions about spinal stenosis and some of the non-surgical ways that we can treat it at Wellward, by all means jump in and ask a question. So Amanda is asking, what age would you recommend this procedure? Amanda, that's a great question. So for people who've had instability in their spine, you can develop spinal stenosis and be symptomatic from it even as early as in your 40s and 50s. Although I'll say that it's less common, but it can still happen. And for those patients, the mild is really the best choice. Unfortunately, there are some insurance limitations because it is a newer procedure. But I've had patients who, they're either going to have to pay a high deductible for doing a surgical procedure with the added disadvantage of all the instability that it creates, the muscle damage that it creates, the muscle scarring, which I didn't even talk about. But surgery creates a lot of scarring within the muscles of the low back. And that's relevant because your spine is constantly in dynamic motion, and any kind of scar within the muscle is a cause of pain because the muscle is not going to be oriented all in the same direction. They're going to be pulling different directions, and that's painful. But going back to the patient who's like in their middle ages and has spinal stenosis, this is a much better alternative because it doesn't do any disruption to the muscle fibers, and they're able to recover very quickly and really get back to a functional state in no time. But really the population that sees this the most is typically the patient over the age of 60. Unfortunately, Medicare is the primary insurance that is covering this, which means that the majority of patients who would be affected by spinal stenosis are going to have access to it. So it's a great question. It's geared for anybody with spinal stenosis. The mild procedure is geared for anybody with spinal stenosis, but in particular, people who have Medicare, it's a no-brainer. I would do a mild procedure on somebody with stenosis much sooner than I would recommend surgery for them for the same condition. You can always have surgery after a mild if it doesn't work, which frankly I haven't seen. Most patients that I've done the mild procedure on to treat their stenosis have done really well. At some point when we repeat the discussion on the mild procedure, I'll introduce some of the patients that have had this done and how well they're doing. Some of them I just haven't even seen back in clinic because they were doing so well. And some people we do have to do a little bit more tweaking to get them a little bit better. So JR, hi, it's good to see you. Thank you for saying hi and thanks for watching. I'll give a few more minutes and see if there are any other questions, but if not, this will be kind of a short show today. We'll pick back up in a couple of weeks, and I think we're going to be talking about ketamine in our next show, which is a medication. It's an old anesthetic that has been used for literally decades in the operating room, but we're finding a lot of utility for it in other avenues. Mostly we have 3 indications for ketamine, and we'll talk a little bit more about that. But the first is in fact for people who have long-standing opioid use or have developed opioid dependency, because that will help reverse some of that opioid dependency. Second is people who have neuropathic pain. It helps with that patient population. And what I have found most interesting is patients with depression. It's been incredibly helpful for that population. Amanda saying, most people that I know have had back surgery, wish they never had it. And I will not say that surgery is wrong in every situation. There are certainly situations in which it's a necessity, but I would say that a vast majority of surgeries that take place, there are things that can be done as an alternative to that surgery, which has just as much proof of or evidence of efficacy with far fewer complications. There's the company that puts out Mild has done numerous studies on it, and I forget what the title of the study that they did was, but they looked at long-term complications of the Mild procedure, which is treating, it stands for minimally invasive lumbar decompression. The complications from that surgery after doing like 20,000 cases was practically zero. I mean, the complications that they saw was excessive bleeding, which I don't really term as a complication. I think it's just, that can happen, and it just means getting just putting some pressure on the wound, and it will stop. Now, if you compare that to some of the alternatives, like the reoperation rate for other types of surgeries that are treating lumbar stenosis is fairly high. I think there's a statistic where 30% of all back surgeries several years out, only 30% of them are showing significant signs of improvement or stability. And whereas with the mild procedure, it's been around for about a decade. It hasn't really been picked up by a whole lot of insurers, so it hasn't really become prevalent. But even still, we've had patients that have had it done, and they don't have any other problems for another 10 years before that stenosis reaccumulates, and they have to have surgery again, or they have to have the mild procedure again. Diane McMurray, thank you for coming in. I see you there. Thank you for saying hello. I appreciate you joining the show. We're talking about minimally invasive lumbar decompression, or the mild procedure for treating spinal stenosis, or what another term is neurogenic claudication, which claudication means insufficient blood flow. Neurogenic means nerves, so it's insufficient blood flow to the nerves, and particularly we're talking about the spine. So spinal stenosis with neurogenic claudication, which is what we're treating, what we're finding as an indication for the mild procedure. So I'll give you a few more minutes if anybody else has any other questions. I appreciate everybody who's chiming in, getting in. And yes, Amanda, I agree. James and I have been talking about his mom for a while, and I would love to see her. I think that the mild procedure is a perfect fit for her because it will avoid a lot of downstream problems. One of the things that people don't realize is that when you're dealing with chronic pain, there's a ripple effect. Like if you throw a rock in a pond, you'll see some ripples, and if you throw multiple rocks in the pond, you'll see multiple ripples that will kind of bump into each other and become bigger ripples. And chronic pain is similar to that. It creates a ripple that has impact on other ripples, and it can accumulate into bigger and bigger problems. So the sooner you can address something like neurogenic claudication or spinal stenosis, or essentially pinched nerves is another term that people use for it, the sooner you can address that, the less damage that will incur in the spine, because when you're hurting, you're going to change how you load the spine, and it will essentially reduce how much you use the muscles of your back. So as time goes on, things will get weaker and become more prone to even other injuries. So Diane is asking, will it help with the degenerative disc disease and arthritis that she has? And so Diane, if the degenerative disc disease and the arthritis continue, then as time goes on, it starts to develop into stenosis, because I was explaining this earlier in the show, and you may not have seen it by just chiming in, but essentially the evolution of spine pain is that you get some kind of an injury that causes instability at a specific level. And if you look at the spine, it kind of curves. It's like a spring, which is a lot more stable than just like a lever. So when you start to get that instability is when you start showing signs with degenerating discs and arthritis. So the principal, or the primary contributor to disc disease and arthritis is instability, or loss of structural integrity of the ligaments that hold the spine together, of the muscles that transfer load from one area to another, of posture, because like I said, a spring is a lot more resilient than a lever is, and bad posture is also essentially losing the curvature of your spine, creating more of a lever situation as opposed to a spring situation. Once all of those changes start to take place, that's when you start to get reactions within the body, where the body is trying to stabilize that structural instability, and that effort to stabilize is what causes the arthritis, because the ligament, the joint capsule around the joints of your back will start to thicken and harden to try to stabilize that movement at that level. And the joint, the disc is not designed for it's not designed for forward, backwards, translational movement. So it starts to tear the fibers of the disc, which then evolves into degenerative disc disease. And then those two together, like I was explaining earlier, if this is where the disc, if this is the spinal canal, we're looking through the spinal canal, and this is where the disc is, and this is where the joints are. Sorry, I'm using one hand to hold my phone, so that's why I can only use one hand to demonstrate this. But the disc is in front of the spinal canal and the joints are behind it. What's happening with degenerative disc disease and arthritis is you get movement up and down, or forward and backwards, of that level in your spine. You've got 5 lumbar levels. Any one of those can become unstable and move forwards and backwards. And as a result, that disc will start to bulge backwards into the canal, and the joints will start to thicken, which will also push into that canal. And so as a result of those two together, you get that spinal stenosis, which causes marginalization or diminishing circulation, and as a result, just insufficient blood flow to the nerves of your back, which you feel in a wider distribution, and it feels like there's that achiness down the back of your legs. That's what the mild procedure treats. It's addressing that stenosis. So even when we treat the stenosis with the mild procedure, you still likely have degenerative disc disease and arthritis, and then we can go back and do some other treatments so that we can stabilize the disc even further, we can strengthen the joints, we can improve the integrity of the ligaments, the glue that holds everything together, using regenerative therapies, and then combine that with exercise therapies, and that's when you start to really see sustainable impact or beneficial effects of some of the treatments that we're doing. So another comment from Amanda regarding James's mother, or her mother-in-law. She is getting around much better now after hip replacement. She's able to get out and about and do it more easily, and that's fantastic. I think mobility is, my physical therapy friends. James is a good friend of mine. He's a physical therapist with Court Physical Therapy. We always talk about exercise and the impact that it has on chronic pain. And physical therapists will often say motion is lotion to the joints. I completely agree. Without mobility and movement, we will, the adage of use it or lose it is very appropriate when we're talking about joints and muscles, because the less you use those structures, the more they'll break down, the less incentive your body will have to build it back up and get stronger. So I'm thrilled to hear that Mrs. Escalani is getting around and moving. That's really critical and can help improve the longevity of her joints and get better. I will say, however, for those of you tuning in, that hip replacements are one of those surgeries that we're doing a lot. We're making a lot of advancements to prevent people from actually having that kind of prevent people from having the necessity for hip replacements. And if we can see people early enough where we can stabilize the hip joint, then it doesn't erode into a point where it needs hip replacement. My goal with what we're doing is to actually maintain biological structures for as long as possible, if not indefinitely, because the advancements that we're making, we're actually making significant strides in understanding why joints deteriorate, why we lose stem cells in our body, or why we have fewer cells that are capable of repair, and how we can amplify or augment that effect with some of the regenerative therapies that we do. Most of it is gearing towards understanding the root causes of what's causing arthritis. And a lot of that comes down to stabilization. It's if the joint loses the ligamentous support structure that holds it together, then it starts to move in ways it wasn't designed for. And that's really what causes erosion. It's not just, something inevitable that's going to happen to all of us. It's those of us who have more ligament laxity or soft tissue dysfunction, where the glue between our bones is not as strong, or the muscles are not doing what they should be doing. That's when you start to see arthritis and erosion of the joint, because the stem cells that are in the joint are not able to keep up with the pace of damage, and that imbalance is what eventually leads to arthritis. So Amanda, off the subject, but yes, we will talk. I'll have you come back in. We've been treating her ankle, and I have some new ideas. I was at a conference a couple weeks ago and talked to some of my colleagues out in Montana, who gave me some new ideas as to what could be causing your ankle pain after that fracture. I'm always going to these conferences, and it's one of the most gratifying things, because it's bringing together a couple hundred of folks that are challenging convention in medicine and challenging some of the norms in medicine to identify things that have longer sustainability and greater effect than what the standard of care is. I wrote 50 Shades of Pain, which is what this show is named after, and the book is essentially about what are the deficits within our healthcare system that are contributing to this opioid epidemic, that are contributing to excessive numbers of surgery, and seeing what we need to do in healthcare to actually get people better, rather than just numbing them and thinking that surgery is an unavoidable, inevitable outcome. Another comment from Diane. Oh great, you have your MRI disc. That's fantastic. So for any patient who's going to come see me, especially if it's a new problem or if I'm seeing you for the first time, please bring your MRI discs with you, or any kind of imaging disc with you. And for anybody who's just watching, I strongly encourage everybody, if you've ever had an X-ray, MRI, CT scan, anything it is, if you've ever had one done, by all means, have them put it on a disc and keep it for yourself. Keep it in your own records, because that information is often very valuable. After about 7 years, health systems will purge their records of whatever they have of you. And so sometimes those old images help make the difference between recognizing if something is just it's been there for years preceding the problem, or if it's a new finding that makes it clinically relevant. So yes, Diane, please bring your disc in next time. Be happy to take a look at it. It oftentimes opens many doors to new treatments, and that we haven't considered, or helps us discover why we're not able to get you to the point where you don't need to come back and see me. I often joke with my patients and say that my goal is to put myself out of business, and I want to get people well enough so that they don't need to come back and see me, which goes counter to the business model of every other pain clinic, or any pain clinic, because they're often benefiting from patients just coming back month after month, getting their medications, and really watching them smolder and decline. That is the reason that I changed course from doing just traditional pain management to doing more regenerative medicine, because my opinion is that there are plenty of patients to treat out there. I want to see patients get well and have them tell their friends who have an injury to come and see me, because my goal is not to have you keep coming back for a steroid shot or for pain pills, or to make it inevitable for you to have surgery. My goal is to actually get you well enough using your own biology and get you out the door so you're back to living your own life. Amanda, thank you for your compliment on the book. I put a lot of work into that, and I credit my family and my staff, my team, for a lot of the support in writing that book. I'm working on a subsequent book talking more in detail about the problems that we have in healthcare that are contributing to the opioid epidemic, how we need to change course, because the opioid epidemic is very directly linked with the pain epidemic. Both of those are not being treated well in healthcare, because both of those issues are we're approaching it with a very short-sighted perspective, and that's causing a lot of the problems. And thank you, Diane. I know that the stimulator that you got is doing really well for you, and she has a spinal cord stimulator which helps control some of the nerve impulses going up to the brain, and it inhibits some of the pain nerves from firing and sending signals up to the brain, and that's helpful. But you're absolutely right. It's part of the solution. It's not the one and only fix. We need to figure out what are the mechanical contributors to your low back pain and see what we can help regenerate or help improve upon. So I've rambled quite a bit, but again, to recap, today's episode is talking about the mild procedure, minimally invasive lumbar decompression, which is a very new treatment that treats spinal stenosis. We had a training in our office just this past weekend where I had the opportunity to train 8 physicians from across the tri-state area, from Ohio to Tennessee. I think we even had somebody from New York come in and learn from us. But it's a remarkable procedure that helps patients avoid surgery, avoid the damage that surgery can cause. What I didn't explain is that a lot of times when you have surgery on your back, it's like the first step of a domino series, because the instability that causes then leads to other surgeries down the road, where surgeons will try to fix that part of the spine from that excessive mobility. And the alternative that we have is using regenerative therapies to strengthen the ligaments and create stability more biologically rather than with external hardware. So please tell your friends about this show. We're going to do this on a bi-weekly basis every other Monday at 6 o'clock. And I'm sorry that I started a little bit late today, but again, we were at this charity event. That's hence the beautiful scenery behind me of the University Club golf course. If you have any other questions regarding spinal stenosis, neurogenic claudication, minimally invasive lumbar decompression or mild, or back surgeries at all, please feel free to send us a message. Bear in mind that this is not a HIPAA compliant medium, so any personal health information that you share is at the risk of being spread across all of Facebook, so please be conscious of that when you send us any questions or comments. But by all means, I want to help create a better dialogue around pain and around the ways that we can treat it in a more sustainable, holistic, natural way that's still founded in science. So you have been listening to 50 Shades of Pain Show, which is the broadcast for our practice, Wellward Regenerative Medicine, where we're trying to take healing beyond medicine. Thank you very much. Thanks for watching. Bye.